Yes, hello friends. I am Dr. Avnish Goel, the educator in dermatology on Unacademy platform. And for your exams, together, let's crack it. So, beforehand, I would like to tell you the benefits of the plus classes. You can learn live from the comfort from your home in the plus classes. You can have unlimited access to all the courses. You can have various practice tests at regular interval. The study material will be available to you in the PDF form. Various batch courses are being organized. You will have mentorship and guidance from all of us throughout the year. Exhaustive coverage of syllabus will be there. Regular doubt clearing and answer writing sessions will be there, as well as you will have live test series. So these are the subscription rates for an Academy Plus platform. If you go for 1 year of subscription, I think that will be the cheapest, around 2100 rupees per month. And if you use this code which is being flashed here, you will get additional 10% of discount. So let us start the multiple choice questions of PGI in dermatology. So they may have multiple correct answers, and I am Dr. Avnish Goel, senior consultant dermatologist. So this is your first question. You have to tell which all choices are true regarding the correct given question. Yes, anybody who wants to take the answer? Before that, I am audible and visible. Yes, if there is no one to answer, since I have many questions to speak on, so I'll give the correct answer. So Bhavna says it's B, which is true according to her. Yes, anybody else? Well, for the given question, that is the choice number one, which says the salmon patch over face fades within a year of life. This is a correct statement. The port wine stain can persist throughout life. This is again a correct statement. The most port wine stains are located over face. This is again a correct statement. Sturge-Weber syndrome and Klippel-Trenaunay syndrome, they are associated with port wine stain. This is also a correct statement. And salmon patch commonly affects the nape of neck. This is also a correct statement. So all the statements are correct regarding the given question. So this is a salmon patch, and the characteristic location is over the nape of neck, where it is called as Unna's nevus. So other name can be Unna's nevus. So it is otherwise known as talk bite, nuchal stain, angel kiss, nevus flammeus neonatorum, and so on. So these are the various names of the salmon patch. It is an extremely common vascular anomaly. It presents with irregular pink red macules with or without telangiectasia. So it will have the macular eruptions which may vary from red color to pink color. The site commonly affected, as shown in the clinical photograph, it is the nape of neck. Otherwise, the forehead, glabella, upper lips and the bridge of nose, usually over the face, they are involved. And the important point to remember is that most of them, they fade in 1 year of age. So the mostly the facial ones, the lesions which are there on the face, they fades by the 1 year of age, whereas those who are located at other sites, they may persist through the childhood. So the salmon patch usually fades by the age of 1 year. This is in comparison to port wine stain. So port wine stain, it is a red homogeneous telangiectatic patch which is present at birth and it persists throughout life. So remember, the port wine stain can persist throughout life. It is often unilateral, painless, and does not bleed spontaneously, and they are never warm on touch. The color varies from pink red to deep purple, and the depth of involvement can be deep. They can involve from skin to subcutaneous to mucosa. Now on the face, the port wine stain, they are along the distribution of trigeminal nerve, and they are associated with Sturge-Weber syndrome and Klippel-Trenaunay syndrome. So these are the two syndromes which are associated with port wine stains. So this is the images of Sturge-Weber syndrome, and the other one is Klippel-Trenaunay syndrome. Now coming to question number 2, following statements are true regarding contact dermatitis except. So Bhavana says B and E, they are incorrect statement. Monica says B is incorrect. So for the given question, the explanation or the discussion, it will be a big discussion, a slightly big, because it will run through the concept making that so here the question says you have to find the except, don't forget except, so you have to find the incorrect statement. So it is the airborne contact dermatitis, it is a incorrect statement because it is a generalized in distribution. So airborne contact dermatitis, it is generalized, while photoallergic contact dermatitis, it is at the sun exposed site. So this is a correct statement for the given question. Allergic dermatitis is strictly defined and localized. This is also a incorrect statement because it is diffuse, a bit diffuse. It is rather irritant contact dermatitis which is strictly defined and localized. Allergic dermatitis has many T cells, as memory T cells and antigen specific antibodies. This is a correct statement. And open patch test is applied over the outer arm. So let us go to the discussion and find out why these statements are correct. So first of all, we should know what is the difference between irritant contact dermatitis and allergic dermatitis. So irritant is due to exposure to substances in toxic concentration. So they develop immediately. So that is why there are no memory T cells and antigen specific antibodies. They have got a short latent period and they are very much defined and localized. So they are localized to the site of application of the allergen or antigen. While the allergic contact dermatitis, it is a type 4 type of hypersensitivity reaction. In it, the memory T cells and the antigen specific antibodies, they are present. The latent period is long, which varies from months to weeks to months, and it has got a characteristic distribution to a particular antigen, and you get a positive patch test. So the memory T cells, they are the features of allergic contact dermatitis. Now this is an image which shows the allergic contact dermatitis. It is due to, as seen in the face, in and around eyes. So it may be due to a substance called as allergen, and it is called as contact allergy, the contact allergy, contact dermatitis. Now the important thing to note is the photoallergic contact dermatitis. So point to be remembered that the photoallergic contact dermatitis, it spares the upper eyelids, those which are not the sun exposed sites. It spares the upper eyelid, under the chin, behind the ears. back of neck and scalp. So upper eyelids which are open, under the chin, back of ear, back of neck and scalp. Since they are the covered sites, they are not involved in photoallergic contact dermatitis. So photoallergic contact dermatitis is called as sun poisoning or photoallergy. It is a form of allergic dermatitis where the rash is confined to sun exposed area only, as the allergen becomes immunogenic following exposure to sunlight. So the allergen will be there all over, but only over the sun exposed site it becomes immunogenic because of sun exposure. So that is why photoallergic contact dermatitis is seen only over sun exposed site, and it produces rash and other systemic symptoms on subsequent sun exposure. So sun exposure is required, and it is very much localized over the sun exposed site as shown in this clinical picture. So the upper eyelids, the behind the ears, as in this picture, behind the ears and the back of neck, below the chin and scalp, they are not involved in photoallergic contact dermatitis. Then coming to airborne contact dermatitis. So airborne contact dermatitis, it is a unique type of dermatitis which does not spare the upper eyelids, retroauricular region and some mental area. So this is a sort of dermatitis which is present all over. So there is both sun exposed site and non-sun exposed site. So it is a dermatitis originating from dust. So dust, sprays, pollen, volatile material, airborne perfumes, they are the cause for this airborne contact dermatitis. It is localized over the face, V area of neck and eyelid predominantly, but sun exposed sites and non-exposed sites are equally affected. So remember, in airborne contact dermatitis, this is the picture. So it does not spare the exposed site and non-exposed site. So how to make the diagnosis? Now I want to stress here that there are various types of patch tests. So this is what I want to stress upon, the various types of patch tests. So what we do, this is a closed patch test. So this is a closed patch test. It is to demonstrate the allergic potential of a substance or delayed hypersensitivity. The patches are removed after 48 hours and initial reading is taken and back is marked with ink. Second reading is taken after 72 to 96 hours and sometimes 7 days later. Why 7 days later? So the reading is taken after 7 days because elderlies, they mount an allergic reaction quite slowly, so that they may show a reaction late, as well as in neomycin allergy. This is a PGI question. So the neomycin allergy shows a late response. So that is why the second reading is sometimes taken after 7 days. Now, this was a closed patch test. Now the open patch test. Open patch test, the allergen is applied over outer arm of skin and left uncovered. So this is a open patch test over the outer arm of the skin and left uncovered. Then we have got a use test. The use test, the suspected cosmetic is applied at distant site twice a day for 7 days. So you apply the suspected antigen at some other site twice daily for 7 days. So this is a use test. Then there is a rapid test, thin layered rapid use epicutaneous test, or called as true test, and it is a ready to use patch test and it contains 23 allergens. So this is again a PGI question which says that the true test is a type of patch test. Now we have dealt about the patch test. Now we should know simultaneously what is the prick test. So prick test is for immediate hypersensitivity reaction done on the forearms. So herein you take the antigen and you take the lancet. So you put the antigen or multiple antigen on the forearms, then prick with the lancet. So appearance of a wheal will give you an idea whether the patient is allergic or not. So it is used to identify allergies to pollen, mold, pet dander, dust mite and food. So this is prick test. Earlier what we have read is patch test. So this is a positive patch test. You can get multiple positivities in patch test. This is called as angry back syndrome. So this is to show you the angry back syndrome, and wherein you can get multiple false positive tests also. So the multiple false positivities can be there in the angry bat, whereas you can get many positivities over the bat. So this is a prick test. It is done on the forearm. And then lastly, to conclude, the another type of patch test is photo patch test. The photo means the patch, and the sun or the irradiation with UVA light is required. So photo patch test. So patches are applied in duplicate. So two patches containing the same material is applied at two different sites, and only the one of them, it is irradiated with UVA after 24 hours. So they are examined after 72 hours. So this is how photo patch test is done, and the interpretation of results. If there is no development of erythema at either side, so at either side, if there is no development of erythema, it means that there is no photodermatitis. Okay, so there is no photodermatitis. If there is development of erythema at irradiated site, then it is photodermatitis. And there is development of erythema at both the sides, it means the patient is allergic to something which is not which is not sensitive to the light, but the patient is sensitive to something which is present in both. So this gives an idea of contact dermatitis. Question number 3. Moiz Ali, I didn't get your question properly, what you are trying to ask. Yes, anybody? Well, if there is no one, I'll give you the correct answer. So Aruna says it's A, which is the wrong statement for the given question. Bhavna is with D. So for the given question, the correct answer one Bhavna gave, that is D, pityriasis amniotaceae. So that involves not the interscapular area, it involves the scalp. And the second incorrect statement, it is the psoriatic arthritis, it involves the metacarpophalangeal joint, it is rather the distal interphalangeal joint which is most commonly affected. Otherwise, so for the given question, the Voronov's ring is due to decrease in prostaglandin synthesis. So that is, it is a very much true statement regarding the psoriasis. Gutted psoriasis, it is common in children and young adults. So this is again a true statement. And acrodermatitis continua of halopio is a pustular erosive disorder of finger and toes around nails. That is again a true statement. So the correct answer for the given question, it is the D and the choice E. Let us come to the discussion. So psoriasis, it is well defined. You get well defined plaques. Then they may vary from no symptom to severe pruritus. Then you get silvery scales, micaceous scales, and this is due to trapping of air. So this much you all know. The Garretta's test, the coherence of the scales gives feeling of scratching candle wax. Auspit signs, pinpoint bleeding due to scraping, due to dilated capillaries. Membrane of bulkily on scraping, moist red basement membrane is exposed and dilated capillaries are seen through it as red spots. So that is membrane of bulkily. Then a Voronov ring, it is seen a zone of hypopigmentation around psoriatic plaques, and this is due to decrease in prostaglandin synthesis. I'll show you the clinical image for them. And the Kovner's and reverse Kovner's phenomena, they are seen in psoriasis, that you know. So this is, you can say, a membrane of bulkily, a split sign wherein you can get the pinpoint bleeding. The white red membrane is membrane of bulkily, wherein you can see minute red dots as dilated blood vessels. If you scrape further, you will get pinpoint bleeding. And the second image shows the zone of hypopigmentation around the psoriatic plaques, and this is due to decreased prostaglandin synthesis. Now, you should know the various types of classification. So there are many types of classification of psoriasis. Just for your information sake, you can classify them into non-pustular and pustular, the psoriasis with arthropathy, and nail psoriasis. So broadly, the clinical type, they can be classified into it. So non-pustular again have the chronic plaque type, guttate, inverse psoriasis, erythrodermic psoriasis, regional psoriasis, unstable nummular psoriasis, SIBO psoriasis, rheumatoid or osteitis psoriasis. So these are the non-pustular type. Again, you pustular type, you have further classifications. Then you can have the atypical type. So these were the typical types. The atypical types can be linear, elephantine or follicular. Then depending on the age, they are classified as type 1 when the age is less than 40 years, and type 2 psoriasis when the age is greater than 40 years. Okay, according to the disease activity, they may be classified as stable and unstable psoriasis. Now, sites, as you all know, the most common site to be affected in psoriasis, this is a multiple choice question, it is the extensors, followed by scalp, retroauricular region, sacral and gluteal region, and umbilicus. Mucous membrane, it is involved only in erythrodermic psoriasis and pustular psoriasis, and it leads to a lesion called as annulus migrans. Flexural psoriasis is also called as inverse psoriasis because there is no scaling, minimal or no scaling in flexural psoriasis. Coming to guttate psoriasis. So guttate psoriasis, it presents as erythematous macule on trunk, commonly seen in children and young adult, but the lesions, they are absent from palms and soles. It follows streptococcal pharyngitis and Auspit sign is negative. So this point is to be remembered. So the multiple small spots of psoriasis is a guttate psoriasis. It follows the upper respiratory tract infection in the form of pharyngitis. Now, the psoriatic arthritis, remember the distal interphalangeal joint is the most commonly affected joint. So, the asymmetrical oligoarthritis, it is the most common. Again, a multiple choice question, which is the most common? It is the asymmetrical oligoarthritis. It is the most common type. Then symmetrical polyarthritis, it is the second most common type, followed by distal interphalangeal joint involvement, arthritis mutilans, and axial arthritis, means the spine is involved with arthritis. They are seen in 5% of patients equally. So the most common is symmetrical oligoarticular. Pityriasis amniotica is well-defined plaque with asbestos-like scaling which are being firmly attached to scalp. So you get asbestos-like scaling over the scalp in pityriasis amniotica. And this is acrodermatitis continua of Halopio. This is a pustular psoriasis involving the tips of hand and feet, and they are associated with erosion and destruction of the nail. Question number 4. Yes, Nicholas' sign is positive in all except. Yes, anybody with the answer? So the Nicholas sign, it is seen, it is positive in pemphigus. It is very much characteristic of pemphigus group of disorders. Then Lyell syndrome. Lyell syndrome is nothing but toxic epidermal necrolysis. So this is the other name for toxic epidermal necrolysis. Then epidermolysis bullosa simplex, the Nicholas sign is positive in that. Hailey-Hailey disease, the Nicholas sign is positive in that also. And the place where it is negative, it is the bullous pemphigoid. So the E is correct answer for the given question. So please note down the places where the Nicholas sign, the disorders in which the Nicholas sign is positive. So Nicholas sign, it is the shearing away of normal looking epidermis from underlying dermis by producing an erosion by applying firm sliding pressure on normal skin. Is it not? You apply a torsional pressure, so the the normal looking epidermis will slide over the dermis. So it leads to formation of new bullae adjacent to the normal on the adjacent normal skin. So positive Nicholas sign, it is seen in pemphigus group of disorders, pemphigus vulgaris, pemphigus foliaceus, paraneoplastic pemphigus. Apart from this, it is seen in Stevens-Johnson syndrome, toxic epidermal necrolysis, then staphylococcal scalded skin syndrome, oral lichen planus, benign mucous membrane pemphigoid, and epidermolysis bullosa. So these are the places where the Nicholas sign is positive. Yes, anybody? Because we are running short of time. So, for pemphigus foliaceus, so remember we are being asked about the pemphigus foliaceus. So remember the Sneer-Usher syndrome. This is also called as pemphigus erythematosus, wherein you get the findings of pemphigus foliaceus plus SLE. Okay, Phogosavagium, that you all know, this is endemic pemphigus foliaceus, it is a variant. Blistering is stratum corneum. It is a wrong statement because it is subcorneal. Blistering in pemphigus foliaceus, it is subcorneal. Yes, Vipul, you are right that the antibodies are against desmoglein 3. So they are not against desmoglein 3, they are against desmoglein 1. And the lesions are in the seborrheic distribution. That is again a correct statement regarding the disease. So remember, the drug induced pemphigus, is again a pemphigus foliaceus type. So for the given question, if I take it collectively, Priyanka, Monica, you answered it as C, Vipul, Bhavna as D. So if you take it collectively, you are correct, but the correct answer will be C and D both for the given question. So pemphigus foliaceus, it is most superficial, sparing the mucosa, antibodies against desmoglein 3. The split is in the granular layer or immediately below the stratum corneum. So it is not in the stratum corneum, it is below the stratum corneum. It is a photosensitive dermatosis, so exacerbated by sun exposure. Involvement of the seborrheic areas with crusting, scaling, erythema, mousy odor is there. So the drug-induced pemphigus, it resembles pemphigus foliaceus, and the drugs which are implicated are penicillin, penicillamine, pyroxicam, phenobarbital, rifampicin, and captopril. So all the drugs with the predominant P. So they are they are commonly implicated. Fucosilvagium, so that is called as wildfire or Brazilian pemphigus. It is endemic pemphigus foliaceus in Brazil, and it is the IgG4 which is commonly associated. So these are the lesions of pemphigus foliaceus, and they are very much localized in the seborrheic areas of the body. And the DIF, which shows the intercellular pattern in pemphigus foliaceus, same as that of pemphigus vulgaris. Then pemphigus erythematosus, it is also called as Sneer-Usher syndrome. It is pemphigus foliaceus plus SLE. So you get IgG and C3. So you get IgG and C3 in a fishnet pattern characteristic of pemphigus foliaceus, plus you can get IgG and C3 in the basement membrane zone characteristic of SLE. As it is associated with SLE, ANA will be positive, and again it is a photosensitive dermatosis exacerbated by sunlight. Yes, the question is taken word by word from the recall books of PGI, and this is a very important question regarding the treatment of. So Bhavna says A and C, they are the correct statement derived from the plant source and they are teratogenic. A, B and E. Ronak says A, B and E. So B is certainly a wrong answer because it is not safe in pregnancy at all. So I'll give you the correct answer. So they are derived from the plant source. You know, they are. It is absolutely true. They are derived from the rhizomes. They are safe in pregnancy. This is a wrong statement. They are teratogenic. Yes, this is true. They are teratogenic. High recurrence rate after treatment. This is again a true statement. An individual variation in response rate. That is again a true statement. So only statement B is wrong. So A, C, D, E is the correct answer for the given question. So the podophyllin, the active ingredient is podophyllitoxin. It is derived from rhizomes of American mandrake, Podophyllum peltatum and Podophyllum immodi. So these are the plants from which it is extracted, usually 10 to 25% solution. 10 to 25%. Remember the concentration. This is again a multiple choice question. 10 to 25% solution in tincture benzoin. It is used. It leads to arrest in cell growth in mitosis. It is severe mutagenic substance. That is why it is absolutely contraindicated in pregnancy. It is effective on moist surface. It has got again a high recurrence rate after treatment. So usually with all the topical treatments, the warts, they have a high recurrence rate. The individual variation in response rate is certainly there, and it is ineffective in common warts, that is Verruca vulgaris and plantar warts. So because I have told you they are most active in on the when the warts are on moist surface. The side effects, it can lead to bone marrow toxicity, renal toxicity and seizures. So people says A, C and D, but E is also a correct answer. Question number 7. Earlier we had discussed the Nikolsky sign, so this is about the acantholysis. Acantholysis is separation of cells from each other, and it is seen in stratum spinosum. So this is a hint. Now please give me the correct answer. So I'll give you the correct answer. So Vipul again says A and B. The acantholysis is not seen in bullous pemphigoid and Grover's disease according to him. So the correct answer is only one here, that is bullous pemphigoid. That is bullous pemphigoid only, where the acantholysis is not seen. So Grover's disease is known as transient acantholytic dermatosis. So this is the name. So the name acantholysis is there in the name itself. So this is acantholytic disorder. Haley disease, it has got acantholysis. Darier's disease is, it has got acantholysis, and pemphigus vulgaris, that is much characteristic lesion which has got acantholysis. So acantholysis, you all know, it is loss of cohesion between the epidermal cells and dissolution of intercellular adhesion sites, is it not? So in pemphigus vulgaris, due to the dissolution of the desmosomes, you get acantholysis. And the acantholytic cells, they are keratinocytes. So this is again a important multiple choice question. They are nothing but the keratinocytes. So herein, the keratinocytes, they assume the smallest possible surface area in the form of rounded ends. So the acantholytic cells, they are rounded keratinocytes with hyperchromatic nuclei and perinuclear halo. This is the statement which is usually said for the acantholytic cells. The classification of acantholysis, we classify them as primary and secondary acantholysis. The primary one having the main etiology of pemphigus vulgaris and various acantholytic disorders of the skin. The primary acantholysis, as I have told you, it is a feature of pemphigus. So all type of pemphigus like pemphigus vulgaris, vegetans is a rare variant of pemphigus vulgaris, paraneoplastic pemphigus, pemphigus foliaceus, pemphigus erythematosus, they all show the acantholysis. Then various acantholytic disorders of the skin, that like Darier's disease, Haley disease, or Grover's disease, which is otherwise known as transient acantholytic dermatosis, they show acantholysis. Coming to secondary acantholysis, it is mainly seen in the infections, so bullous simpatico, staphylococcal scalded skin syndrome, viral infections like herpes simplex, varicella zoster and varicella. Then it can be seen in solar keratosis, squamous cell carcinoma, and acantholytic dyskeratotic epidermal nevus. So I think you should not go for that much detail. So remember the infections which are the causes of secondary acantholysis. So remember, acantholysis primary and secondary. So primary, the cell becomes rounded first and then there is detachment, and secondary acantholysis. So in the primary, first there will be detachment, then the cells will become rounded, and secondary acantholysis, first the cells will become rounded and then there will be detachment from each other. So these are the various causes of primary and secondary acantholysis. So you can read and you can find out which are important in that for your examination. So the causes of primary and secondary acantholysis. Coming question number 8. This is again an important question as far as your examinations are concerned. Well, for the given question, the photosensitive dermatosis, all the choices, they are photosensitive. The pellagra, the niacin deficiency, the photosensitive dermatosis. Pemphigus is a photosensitive dermatosis. Pemphigus erythematosus, I have just now told you. Pemphigus, foliaceous and erythematosus, they are they are photosensitive dermatosis. So SLE you all know, that is photosensitive. Dermatomyositis is also photosensitive, and seborrheic dermatitis, they are the photosensitive dermatosis. So all the choices, they are photosensitive dermatosis. So classification of photosensitive dermatosis. So it is a big classification. It can be classified under acquired or idiopathic, metabolic cause, neoplastic cause, chemical or drug induced, and genetic and photoaggravated dermatosis. So these are the classifications in which the photosensitive dermatosis, they are classified: acquired, metabolic, neoplastic, chemical and drug induced, genetic, the disorders which have genetic propensity to have photosensitivity, and photoaggravated. So the acquired, the five important, the photosensitive dermatosis, they are polymorphic light eruptions, actinic prurigo, hydria vacciniforme, chronic actinic dermatitis, and solar urticaria. So these are separate entities. So these are acquired disorders, photosensitive dermatosis. Metabolic, it can be seen in porphyria cutaneous tarda, pellagra, kwashiorkor, Hartnupp's disease, and carcinoid syndrome. So these are the metabolic causes of photosensitive disorders. Chemical and drug induced, they can be porphyria, or it could be exogenous secondary to systemic or topicals. Then genetic causes, they can be xeroderma pigmentosa, Bloom syndrome, Cockayne syndrome, trichothione dystrophy, Rothmund-Thompson syndrome, and erythropoietic porphyrias and protoporphyrias. Among the photoaggravated dermatosis, so this is something which I want you to pay attention. So the acne vulgaris can be a photosensitive dermatosis. Atopic dermatitis, it can be a photosensitive dermatosis. Bullous pemphigoid, apart from pemphigus, can be a photosensitive dermatosis. Lichen planus can be photosensitive. Lupus erythematosus and dermatomyositis, you all know. Psoriasis can be a photosensitive dermatosis. Pemphigus, we all know, pemphigus foliaceus and erythematosus. Seborrheic dermatitis is a photosensitive dermatosis. Erythema multiforme, it can be a photosensitive dermatosis. Hailey-Hailey disease, herpes simplex, and Darius disease. So for most of the dermatosis, you will assume that they are not photosensitive, but this is the classification of photosensitive dermatosis given in the standard textbooks, and PGI question, this is the question taken word by word from the recall textbooks of PGI. So for the given question, skin markers of internal malignancy. So this is a question, it has been repeated many a times in PGI. So acanthosis nigricans is a skin marker of internal malignancy. Necrolytic migratory erythema, it is certainly a marker. Even bullous pemphigoid is a marker of internal malignancy. And you know, dermatomyositis is commonly associated with internal malignancy. So necrobiosis lipidica, it is a marker for diabetes. So this is the only incorrect answer. So A, B, D and E, they are the correct answer. So please note down the important skin markers of internal malignancy. So they can be a paraneoplastic dermatosis syndrome, and depending upon the strength of correlation, they can be classified into strong, intermediate and with weak correlation with the malignancies. Among the strong correlation with internal malignancies, they can be acrokeratosis paraneoplastica or Bayes syndrome, erythema gyracum repens, necrolytic migratory erythema, palms, also called as acanthosis palmaris, paraneoplastic pemphigus. Then Poems syndrome. Poems, P for polyneuropathy, O for organomegaly, E for endocrinopathy, M for M proteins, and S for skin changes. And recurrent migratory thrombophlebitis, also called as Trocheus syndrome. So these are the having the highest correlation with internal malignancies. Now coming to moderate correlation, it could be the neutrophilic dermatosis like Sweet syndrome, pyoderma gangrenosum and dermatomyositis. You know, dermatomyositis, it is commonly associated with nasopharyngeal carcinoma and ovarian carcinoma. So nasopharyngeal carcinoma in males and ovarian carcinoma in females. Among the weak correlation, it could be acanthosis nigricans, which has got a weak correlation, lesser trillite sign. So this is sudden eruptive seborrheic keratosis, and erythema annular centrifugum, bullous pemphigoid and digital clubbing. So they are having a weak correlation with the underlying malignancies. So the skin manifestations of diabetes, it can be xanthomas, can certainly be the manifestations. Necrobiasis lipoidica diabeticorum. So this is again very much specific for diabetes. It is seen over the anterior shins. Granuloma annulare can be associated. Bulliosis diabeticorum, that is again associated, while macroglossia, it is a feature of acromegaly and not of diabetes. So only to name a few, the cutaneous manifestations of diabetes, that can be xanthomas, infections, ischemic changes leading to foot ulcer, delayed wound healing, necrobiasis lipoidica diabeticorum, granuloma annulare, various acquired perforating disorders. So these are four acquired perforating disorders. They can be seen in diabetes, they can be seen in liver disorder, they can be seen in kidney disorders. So apart from this, bulliosis diabeticorum, acanthosis nigricans, diabetic dermopathy in the form of shin spots, scleroderma diabeticorum, pseudoscleroderma, and lipoatrophy, they are the commonest association with diabetes mellitus. So they are the skin manifestations of diabetes. So we have only two more questions to go. We have already exceeded 20 minutes of time. So erythroderma is commonly caused by, so you have five choices. So erythroderma is caused by all except B. So Vipul gave me the correct answer. So pityriasis versicolor, tinea versicolor, it is not associated with erythroderma. Rest all conditions, the psoriasis, the eczemas, the lichen planus, the pityriasis rubra pilaris, they can lead to erythroderma, but not the tinea versicolor or pityriasis versicolor. So this is erythroderma wherein the greater than 90% body surface area is involved. It is characterized by scaly erythematous dermatitis involving more than 90% body surface area, discovered by von Hebra in 1868. It is the extreme state of skin dysmetabolism giving rise to intense erythema and scaling, and it can be fatal due to metabolic burden and complications. Now, you should know the percentage of each lesion causing erythroderma, because the questions, I have seen question, the most common cause or the least common cause. So the most common cause for erythroderma, it is the eczemas. So eczemas, they are the most common cause of eczemas. Among the eczemas, it is the chronic actinic dermatitis followed by atopic dermatitis as the cause of erythroderma. Apart from eczemas, it is malignancies, second number, which can lead to erythroderma. Then comes the psoriasis in around 14%. At the fourth, it is the idiopathic various other causes, and the last to come is the drug induced. So these are the causes of erythroderma, the various prevalence of the disorders. So eczemas, malignancies, psoriasis, they all are there, but tinea versicolor is not a cause of erythroderma. This is a book reference to tell you the various causes and their percentages is the cause as a cause of erythroderma. This is the last question of today's discussion. So the Bhavna gave me the correct first answer, and the correct answer, it is the cradle cap and napkin dermatitis. They are type of seborrheic dermatitis. They are not dermatophytosis. Otherwise, Majorchi's granuloma, which is a dermatophytic folliculitis, it is a type of dermatophytosis. Tinea imbricata is a differential diagnosis. It is a type of tinea corporis. Tinea globrosa, it is again a type of tinea corporis. So these are the types of dermatophytosis, that napkin dermatitis and cradle cap, they are not the true dermatophytosis, they are the seborrheic dermatitis. So this is Majorchi granulomas. So it is caused by Trichophyton rubrum seen in women who shave their legs. So fungal hyphae, they invade the hair follicle, and it is folliculitis due to dermatophytosis, and it appears as folliculocentric papules. So again, it presents as a papular eruption, it can be a nodular eruption, and it is around the hair follicle, and it is dermatophytic folliculitis, the Majorchi's granuloma. Tinea imbricata. In tinea imbricata, you get widespread multiple concentric polycyclic scaly lesions. So it can present with concentric polycyclic scaly lesions with minimal or no inflammation or vesiculation. The concentric rings suggests tinea the concentric vesicular rings, it suggests tinea incognito. So in tinea imbricata, you do not get vesicular eruptions, but vesicles, if it is there, the concentric rings with vesicular eruptions, it suggests tinea incognito. Tinea glabrosa, so it is superficial fungal infection of arms and legs, especially over the glabrous skin. However, it can occur at any part of the body. So tinea glabrosa is the other term for tinea corporis. So the cradle cap and napkin dermatitis, they are part of seborrheic dermatitis. So with these words, I am over with the 12 questions which I posted for today's discussion and for PGI. So I thank you very much for patient listening. So before closing, I'll tell you the various uses of live classes. You can have the plus live classes, the direct interaction with the educator. You can have test series and quizzes, various doubt clearing sessions. All the educators are there with you throughout the year for your preparation for examinations. You can download the Unacademy learning app and get started. And these are once again the subscription rates. The 1 year subscription is mentioned here with around 2,100 rupees, and with the code which is being flashed here, you can get additional 10% of discount for it. So with these words, I wish you good luck for your examination. Stay safe and keep learning and keep enjoying. So thanks for watching and thank you very much.